Good afternoon. Clarence Williams, Director of Primary Care Community Medicine at Luminis Health here in the Maryland region. As always, it's good to be back amongst colleagues with CTeL.
It's gonna drive me crazy. We'll just hand it back and forth. I'm Penni Kyte. I said earlier, I'm with Ballad Health, which is in Southwest Virginia, Upper East Tennessee, 20 hospital system across there. I'm the Digital Care Strategy Officer for Ballad. And even though I've got responsibility for telemedicine, I also have responsibility for patient transfer center, centralized bed placement for the 20 hospitals, and EMS encoding and air medical into the hospitals. And I say all that because when we talk about a lot of we use telemedicine a little differently to try to connect care with all the patients.
So some trends and things that we've seen on the health system side, at least over the past year or so. For the first time, it seems like the industry is not necessarily waiting to see what CMS is going to do related to telehealth policy, but there's been enough confidence on the health system and private side where we're actually seeing codification of telehealth benefits and policy reimbursement. So as far as back as I can remember, I think this is the first time that we've seen that much confidence on the provider side of the organization or of the house, where these organizations are actually confident enough in allocating resource and budgeting for it, knowing that CMS maybe has a less certain pathway. So glad to see that on the private payer side and some of the Advantage plans, that there's enough confidence to move forward in that direction. Obviously, there's been a lot more emphasis on linking outcomes to reimbursement. Just out of curiosity, by show of hands, how many of you have value-based contracts that sort of structure your intention around virtual care? Okay, I would say in this market, Maryland, which is pretty virtual care, digital health friendly, we actually have the ability to achieve positive operating results using digital health and telehealth programs, specifically around remote patient monitoring and other types of modalities. I think it's really interesting in the past year or so that the value-based care agreements that I can think of have been friendly enough to where it's been relatively easy to show a value statement by implementing virtual care. I don't think it's always been like that in the virtual care space in years past. So I think there are some markets that have more and more confidence as well as friendliness toward reimbursing these type of tools in a sustainable way. I would also say that it seems like on the payer side, there's more traction around using AI for administrative tasks, things like eligibility and enrollment verification for covered lives, whether they're a MAC or a Medicaid population or a private pay. I think that the insurance side of the house is probably ahead of the curve compared to the provider organizations related to using AI for administrative burden types of activities. So at some point, I think that we on the provider side of the house might be able to catch up by leveraging AI for some back-end support to help reduce some of our administrative burden. Speaking of administrative burden, one of the provisions in the Big Beautiful Bill is the work requirement for Medicaid enrollees. And based on what's happened in other states, we can expect that there would be some level of administrative burden increase. If you can think back or if you're familiar with other states such as Arkansas, New Hampshire, or Michigan in the past, some of their results didn't necessarily drive an increase in employment, but they actually kind of drove disparities in healthcare. So you actually saw some disenrollment of Medicaid enrollees across all three of those markets. So one of the questions that I have on the provider side is moving forward when the big beautiful bill is enacted, what does that administrative burden look like, and how will organizations, quite frankly, that have emergency departments or who would play a bigger piece in the safety net health system space, how will they in turn use these tools to maybe reduce some of the exposure or provide access to these populations? So to me, that kind of begs the question, what are some of these organizations who are anticipating that administrative burden to kind of increase for them over the next couple of years? What are they doing to kind of get those indigent care lives or projected indigent care lives into some form of a value-based structure to ensure that if they're using digital tools, there's some cost feasibility there? And then I think RPM is finally becoming scalable in a way that's financially sustainable. If you look at the ability to negotiate value-based care contracts for chronic disease management and metrics that support the delivery of that care, I think there's an ability to suddenly have a positive value statement and a safe investment RPM where you can actually have an operating profit. So I can say that for the first time in my career, we've seen this, a current organization for CHF or congestive heart failure patients. And it's been really instrumental in managing those lives, starting in primary care and reducing not only the risk, but some of the downstream utilization of health services, for example, readmissions and other types of procedural interventions. So I think that there are some opportunities there with what we're seeing in the payer space, but the payer space, like the provider side of the house, is also, I think, increasingly adopting a consumer strategy. So if you think back 10, 15 years ago, you probably didn't see as many digital tools being deployed for beneficiaries from payers. And now all of a sudden, it's almost as if they have their own consumer first strategy, and many do, where they're using digital tools first before you necessarily access brick and mortar resources. So I think that for the first time, we've kind of seen a leapfrogging effect with digital adoption on the provider side of the house versus the payer side, especially as it relates to the ability for the private payers to move forward in confidence and sustainably write policy and codify the ability for provider organizations to actually use these tools for the long term.
I'll just give you some things that we're dealing with right now, and please jump in. I don't want to feel like I'm sitting here with a dissertation. I know that our finance department has completed an assessment of the big beautiful bill. We're expected to lose $125 million in the next 3 years, starting in FY27. I actually had a conversation yesterday. What is today? Tuesday, with our system CFO. And that's one of the reasons we're looking so much at AI technology and in that service, because we know we have to reduce our footprint some way, somehow. From a private payer perspective, because it's been kind of schizophrenic, whether or not we're going to get paid, not going to get paid, because a lot of our private payers, especially on the Tennessee side, they're not Medicaid expansion. Virginia is Medicaid expansion. So we've got both sides going on. We can't 100% rely that we're going to always get paid. So that's why we kind of flipped. And what we're trying to use is telemedicine to bridge a gap. For example, we have a 6-month wait time to get into a neurologist or a cardiologist, because we don't have enough for all of the patients, especially in the more specialists you get, the longer it is. So one of the things we're trying to do is not focus so much on the revenue, but focus so much, can we get that patient into that specialty level of care? And that way, either A, keep them out of the hospital, because our hospitals, we've got 3 tertiaries and they're busting at the seams, to try to keep them out of the hospital. And if they are in the hospital, if I can provide that telespecialty coverage, I can keep them at that rural hospital or that community hospital, which is a lower CMI payment as opposed to my tertiaries, which, cost more. The other thing we've had to do, we had a mass exodus of a specialist GI. They decided they were not practicing in the hospitals anymore. And so we lost a whole bunch of GI and had to pull in locums. So in order to optimize our locums that we were paying to do procedures, because we have a lot of GI bleeds in our area, we actually implemented tele-GI to assess the patient pre and post so that locums GI could do nothing but focus on doing that procedure. So we've really tried to think outside of the box in order to not rely as much on whether or not we're going to get reimbursed on every single telehealth. The other thing I will say too, and I've got some slides here that I'm looking at, even though we're as chronic, most of our patients have comorbidities, a lot of COPD, a lot of CHF, a lot of diabetes. We're morbidly obese in our area and so forth. We're 72% Medicare Advantage across our area, which is pretty high. Our highest utilizer for Medicare Advantage, our highest payer is United Healthcare. I need not say any more else about United Healthcare. Ballad actually filed a lawsuit against them along with every other healthcare system because of the reimbursements there. So I'll kind of stop there, see if anybody has any questions. Go ahead.
So the providers conducting your telehealth or your own providers, are you outsourcing that to external providers based upon it? You talked earlier about cost.
It's a mixture. So if I have capacity within our employee-owned providers, then we use them. Telecardiology, I have some capacity. I just can't get them physically 4 counties over in time for it to be efficient. Tele-GI is completely a third party that uses our telemedicine vendor and so forth. So we've got a mixture. We do try to go internally first, then we try to go to the community. We've got a couple of community practices locally owned, but honestly, they're starting to get swallowed up by the Optums and everything else. And then we have a local university, East Tennessee State University, and we use their providers when we can. We try to keep things as local as possible first. It's not always the case.
You had mentioned United Healthcare, and so that makes me think of some of the issues we're currently seeing around remote monitoring reimbursement.
Yeah.
I'm wondering if either of you could talk about some of the trends you've been seeing specifically on remote monitoring, because I know there's a lot of organizations who are either in the space as providers or developers when it comes to remote monitoring. And there's definitely been some changes over the past few months there as well.
So I'll start and then hand it to you. So we have a pretty good footprint of remote patient monitoring. My average patient age is 75, believe that. And they do really well on it. We currently, most of those patients, we are on the MA plans. So we don't bill for them yet. They're actually we use that to try to keep them out of the hospital. And I'll hand it to you.
Sure. So we've been historically, even prior to my tenure, pretty particular about what RPM solutions we implement and the question around building versus buying solutions or using third-party vendors. And we found that it's more financially sustainable if we choose certain populations that we have more control over in terms of their continuity of care throughout the system. And for us, that's really diabetes and congestive heart failure. And so the strategy there is not to ask providers who are in-house to do less profitable activities because of the nature of how their incentives are, or the physician contracting, if you will. So we use a third party to manage some of those CHF patients. And that allows us to aggregate the data and sort of digest it in a way that filters out the noise, and it gives us actionable insights that's integrated with our EMR, native EMR, which is Epic. And so over the past several years, that's actually generated a slight profit for those patients from a fee-for-service standpoint. And then when you start looking at the value-based impact of that intervention, there's also significant savings there, as well as award payments or quality incentives for achieving certain milestones with that population. So I would say, like, in an ideal context, there are probably multiple domains in which the organization will evaluate the feasibility of RPM, but it's extremely difficult to have a sustainable model from a financial standpoint in the absence of value-based care. I am aware of some safety net organizations who use RPM as a way to kind of hedge their bets and perhaps reduce some emergency department utilization, but for the most part, it works much better if it's within a value-based care context.
Penny, I wonder if you could elaborate a bit on the observation you made that your RPM service is helpful from the standpoint of diminishing hospitalizations and other big ticket utilizations. Do you have statistics on that, or have you considered publishing anything about it? What can you flesh it out a little bit?
So I do have statistics. I don't have it in front of me, but I can pull it up in a bit and share. We have been working. We're one of the code on ATA, where they're working through some data analytics there, to try to publish some RPM data. We've been pretty successful with keeping those RPM patients out of the hospital. But we're specific, like he had said, we're specific to COPD, CHF, diabetes. That's the only three, and we've run it through whatever primary care office that they're connected with. The primary care office still wants to be the one kind of leading that, so ours is internal. We hadn't outsourced it to a third party, but I'll get that data while he talks.
Are there any questions or comments from folks attending virtually?
This one for you, Clarence. I thought I heard you say that Maryland seems to be a relatively happy hunting ground for RPM and other service. Why is that? What's the distinction between Maryland and other states?
There are many, I think, players in this market. Like many major markets in the DMV area, you don't necessarily see a lack of specialties in terms of access issues. The wait time might be, expanded, but you don't necessarily see a lack of resources available in the area. So I think that's one thing. I think we have roughly just under 60 contracts with payers in a relatively small geographic area. So I think that type of market competition is also helpful compared to some of the stories I hear from other counterparts who are in other markets that are extremely sensitive to one or two major players. So I think the diversity in players is helpful there. I also think that the ability to negotiate with payers here is probably a little better than a lot of other markets, just because there is so much competition, and it seems like it's fairly agreeable in the region as far as relationships between the providers and the payers. Then I also say the population here is pretty diverse in terms of really every metric that you can define, especially on the payer mix side, which gives us a canvas of more sustainable programs. So we have some engagements in rural Maryland as well as, the major metro areas. But we have a pretty good payer mix that you would, I think, typically see somewhere in the mid-Atlantic to northeastern corridor in the larger metro areas. And so I think that context kind of gives us an advantage in terms of having the ability to be semi-rural in some instances, but also be urban in a state that will allow us to do a lot of digital health in a reimbursable way that's not necessarily subjected or limited by the historic restrictions around reimbursement for telehealth. So it's kind of a perfect storm in terms of favorable market conditions as well. I would kind of couch it.
So I've got the data for FY25. We have had overall adherence of glucose monitoring, 47%, blood pressure, 63%, pulse ox, 63%, weight management, 65%. And like I said, the average age was 75, and the average enrollment length for our patients is 212 days. The one thing I'll remind everybody, the majority of these patients are MA patients, and even if they are not, we're not billing for them yet. The other thing we've had to be very careful of, because we actually just changed from one remote patient monitoring vendor to another, is broadband's really important. A lot of Southwest Virginia and Upper East Tennessee are in the middle, like I said, of the Appalachian Mountains. So there's no broadband there. Virginia actually just put like 25 million in the last year and a half into broadband in that area. So we have to have a backup on the RPM. So we use cellular, but we have a tablet that will connect to cellular if cellular is available, but we've also had to make sure that it will hold the data until that patient can get on some kind of wireless if there is no cellular available, because in certain areas there is nothing available. And for us to have that high of compliance with as much broadband issues, and in case any of you all know any of these counties, we're talking about Russell County, Virginia, and Washington County, Virginia, Smith County, Virginia, all those little counties up in the Buchanan County and so forth. Those are the little counties we're talking about.
I wanted to ask it about another development from the past few months, and that is with federal employee health benefits. There's been some revised standards that were put out that limited access to a number of services, one of which was telehealth, and that federal employee health benefit plans are moving forward looking like they'll be very limited when it comes to their coverage and reimbursement for telehealth services. Is this something, now of course, federal employee health benefit plans aren't governed by a lot of the state laws that mandate coverage and payment parity, like a lot of other private payers. But do you think that there's anything significant in, at least when it comes to the federal employee benefits plans, and whether or not that might have influence on other private payers?
I think it's going to have influence on private payers. I was looking at some of my emails before I came here, because I get a weekly email from our payer relations. And we're already seeing, especially on the Tennessee side, we're already seeing certain payers in the state of Tennessee, Blue Cross Blue Shield be one of them, start to limit what they're paying. I haven't seen it as much on the Virginia side, but Tennessee is really starting to limit. Like they were covering certain forms of telehealth, and they were covering asynchronous, virtual urgent care asynchronous to a point, and now they're not covering at all. That's one of the most recent updates. As far as federal employees, most of our federal are from the VA. I think you'll probably have more federal on your side.
So I would say in this market, there's a lot of sensitivity to FEP Blue, those plans. So I think it goes back to provider organizations' ability or opportunity to negotiate those value-based agreements. I can say, yes, there has been some movement with that population, knowing how large of a patient base that is here. But, again, it's really, I think, boiling down to what populations are we targeting with these interventions, and how can we successfully negotiate with the payers around that. I do expect that to be cyclical, and at some point I expect it to maybe swing back the other direction. I can recall several years ago when many of us were trying to navigate the world of narrow networks for health plans that had partnered with a particular solution to provide virtual care. But we've also found that a lot of those patients are willing to pay cash depending on the service that they're accessing, especially if it's like virtual urgent care or same-day primary care. So yes, there has been some movement, but at this point, I wouldn't say that beyond those of us in this market, I'm not sure how significant that movement will really be as far as reimbursement in the ecosystem for the virtual care. So, but we do expect that to swing back the other way at some point.
I do have one thing I've been wanting to say all day to get other people's opinions on this. So I've had to explain to a lot of people, family and friends, because I live in a red state? Is that, I live in a red state and the other one's a blue state. So you have lots. And conceptually, the general public does not understand what the financial impacts of the big beautiful bill means. And so I've had to explain it to many people of, this is what it means for Ballad. We're going to have to consolidate services. We're going to have to do this. We're going to have to do that. And I've often thought, is it like AI? Is it like telemedicine 20 years ago? And I was in a different role 20 years ago, but I remember us trying to teach our local community, at least, because the average education in our area is 5th grade. Try to help the public understand what exactly is going on with their benefits. And I don't know how to do that and simplify it. I've done it with a couple of people close to me, and they're like, oh, well, I didn't know that. And I'm like, yeah, we get paid 50 cents to $1 when you come. And now they're going to cut that more. So, and have to walk down through there. But is there something, do you all think that would be something that we could actually get off the ground? Because I think the more that the general public knows, then the more that they would understand some of the policy stuff going on. Does that make sense? Am I making sense at all? Okay. Because I think that's a huge gap that sometimes is why certain people don't understand when we say healthcare is getting killed right now. They don't generally understand that because they think they have Medicare, we're getting paid.
What people understand is what they have to pay.
Yes, exactly.
Not what you get paid, but what they have to pay.
Well, and a prime example, and I know I'm getting probably a little more personal, but a prime example is they also think if an ultrasound costs $300, you're going to get $300 for that ultrasound. And that's not how healthcare works.
But they have to pay for it out of pocket.
Or they won't have it. I don't know. I've just been wanting to throw that out all day long because I do think there is a definite education opportunity because that's where the masses could really help us. But we've got to put it in simple layman's terms. I'm sorry if I started a whole roller coaster.
Penny, I think that may well be true. I suspect, without really knowing, without having studied this, that to do that, you may have to start with Medicare 101. That is, lay out what the program means and doesn't mean at the most fundamental level before you begin tackling the big, beautiful bill. Because I suspect that a high fraction of the population served by Medicare, a high fraction of the taxpayers, fundamentally don't know even rudimentary aspects of the program, its origins, and in particular its limitations. So it's an ambitious project, because I suspect you're not going to be able to assume any reasonably, even a modest level of basic understanding before you start talking about how the big beautiful bill changed what used to be the law, because I don't think people knew what the law was before.
No, and just simply, they thought we all had contracts. The conversations I've had, they thought we've all have contracts with private payers, CMS and Medicare, and that we're getting reimbursed exactly what we need to get reimbursed in order to do that. And that's not how the contracts work.
That reminds me, I used to listen to a radio show here in the DC area on public radio. It was called This Ain't Your Grandma's Medicare. And it was actually a call-in show where people who had questions around navigating the benefits of Medicare and the policy changes, they would call in, and experts would actually kind of walk them through that. And regardless of what area in the country you are, what the socioeconomic status is, it's a pretty complicated set of benefits. And so that's one of the interventions that I've seen that work pretty well. I think it used to come on once a week. I used to listen to it during the pandemic, during all the changes.
That's what we need Lydia and Chris to do.
There was a related NPR program, and I don't know if it's still on the air, that would examine a particularly outrageous bill from a hospital or from a clinic or whatever, that some expert would explain, and it seemed to have quite a following. What appeared to a layperson to be a relatively simple visit for a simple problem would run into 5 figures or more occasionally, and there was a speaker who I think may have been a physician but was well versed in these matters, would explain, well, this is how you got to this number. And the other thought that occurs, besides the Medicare 101 concept, is I have real doubts that most folks have any earthly idea what it costs to run a hospital or to run a health system, or for that matter, a 2-doctor clinic, and the discrepancy between what those costs are and what reimbursement, including even commercial carriers, bears to those costs. I suspect that's not known among a large fraction of the population. Would it be possible, in Pennsylvania where I grew up, it was mandatory that every kid in high school in the whole state had to have a course in health. In my case, the course in health was taught by the football coach, who would tell wonderful war stories about football games going back decades. It was very entertaining. Had nothing to do with health. I've often thought, why not use a forum like that to, for example, educate kids about why you do and why you do not go to the emergency department? Or here's Medicare 101, or maybe 91 for high school. And maybe the differences between what we as taxpayers pay, what we as ratepayers pay, and what hospitals get paid and other providers for a given service. It seems to me that if there's to be any chance that this educational approach is going to work, you're going to have to start at the basic level and maybe with kids.
I just think that until there is some just very simple level knowledge from a voter, then I don't know if it's going to be, with what we've run into trying to get policies changed and approved and so forth, until that voter understands and they start putting a lot of pressure on people. Because right now we're probably being recorded, but right now it's just all finger pointing back and forth. And in a personal opinion, it's both sides, blah, 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 blah. But at the end of the day, when I cast my vote, I cast my vote that you're going to vote according to my beliefs, whatever. And that it cannot be what's happening right now, because I see it in my own states, 2 states that people think that their senator, congressperson, whomever is standing up for one thing, and they're not. They're going the other way. So I think there's an education opportunity. I do like the school part, because I feel like we could do a small part with that with my school telemedicine, and maybe get some flyers and stuff out or something like that, and start at least that younger population, help them understand. And maybe when I retire, they'll know by then. I took us down a rabbit hole, Lydia. I'm sorry.
No, I think it's important, especially I think it also ties into the discussion we had earlier this morning about trying to make the connection between the telehealth flexibilities and the fact that they are short-term temporary waivers set by Congress, and communicating that to patients, and what the difference between like an institutional practice, like what is a Ballad Health practice versus what is state law or a payer policy or federal law. And I think it, again, just goes to the need to be able to communicate that, and a lot of the challenges that we discussed this morning as well.
Yeah, and to give you an example, we put that disclaimer up on our virtual urgent care and behavior. We put that disclaimer up everywhere it would be affected, that as they're going through their consent form process and so forth, they would know that they could possibly have to pay. And inside of Ballad, a leader reached out to me and said, one of my patients just got this. I don't understand why. And I had to explain to someone that should know why we had put that there. The communication didn't get down. So it was interesting that even those that we think should know really don't know, because it's so complicated. We may be the fastest one today. Yeah, everybody's ready.
Just checking the chat and Zoom rooms, see if there's any questions or comments from virtual folks.
There's one other comment I'll make, and it has nothing to do with payers, but it goes to a comment made earlier about AI technology and it taking away jobs. I'm of the belief it will not take away jobs, it will redirect jobs. I think AI is the industrial revolution all over again. If we look at what happened there, people had to learn new job roles and move to different job roles. If you don't constantly learn, you get stale. I say you get stale and you die. Never quit learning. And same thing here. So, history repeats itself. I think we're in the middle of another type of industrial revolution, and it's now AI. People were scared of the industrial revolution. Now they're scared of this, but those people will have jobs. It's just, they're going to have to learn that new job role. And I think a lot of it will be over in that AI area, AI field, because I'm assuming everything that I've learned about AI, and I'm not a subject matter, is that AI will end up being more like a data analytics department, where at some point it will be less vendors and more in-house, where you're building and monitoring your own AI once we get smart, intelligent enough to have that.
How do you see that changing the landscape of reimbursement?
Can you explain a little bit?
Like, I guess the traditional model of reimbursement, where like you bill for the codes and services that are being performed. If there is this fundamental shift in the way that the art of medicine is practiced comes about through AI, do you see, I guess also going back to our conversations about needing to update or change the framework that we use for billing, do you see that a different way of operating, changing the way that reimbursement overall would look for a hospital practice clinician?
Well, I think the payers will expect us to reduce their cost if we're using AI. So if they reduce our cost, they're going to reduce our reimbursement. I actually had this conversation with our system CFO too, because he thinks at some point payers will not reimburse dollar for dollar for video, for telemedicine. This was their discussion. And I said, why do you think that? He said, well, you have bricks and mortar that you have to pay for with a face-to-face. And I said, well, I would argue the technology that it takes to run telemedicine is just as expensive as that bricks and mortar. I said, so you're basically trading off one for the other. And I think we're going to have to articulate that. I think the first gut is that payers are going to expect us, okay, you're more efficient, you've done this, then you need to reduce your, you need to give us a break.
Move a lot of costs from the system. But the AMA said, well, there's no doctor effort. There's no way for us to read anything ever. Why? Oh, man. That was just but also the telehealth part, which is significant investment there. So I think to the Laura's point earlier, there's just a very broken system that doesn't recognize costs. And I have to believe that bigger companies than us will try to influence AMA or whoever to create something to cover the cost of all of this technology. I don't know how aware of any
There was a couple RFIs in some of the annual CMS rulemaking this year, trying to get some sense of how they might put together a reimbursement framework for AI-enabled services, software as a service, and kind of how to specifically update their practice expense. CTeL and a lot of others, we contributed comments to that. And then in the final rule, CMS said, thank you for your input. We will consider this in future rulemaking. But there was an RFI, we responded, and a lot of others did, about some of these issues surrounding reimbursement and specifically looking at some of the practice expense methodologies. Yeah, I think Chai kind of has tried to do that, but there's also Chai and HHS leadership. I think even RFK got involved, got into a very public fight over Chai's role in any of these conversations, and I think that's kind of the largest health AI lobbying group out there right now. And so whether or not it will actually have any influence within HHS, at least in the near-term future, seems unlikely. But there has been some organized efforts around this. And they have some pretty big players in the organization. But I think as long as HHS sees them as a regulatory cartel, they might not have much influence, at least within HHS.
Well, we look forward. Thank you again for this panel and this conversation. CTeL is going to be hosting regular micro events throughout 2026, 1.5 hour roundtable discussions that will oftentimes be in person, but you could tune in virtually. 1 second. So it looks like Zuhal Hadari from APA just asked a question regarding Lydia's question about payment. Providers will also have a way more data to analyze and act on. It's a concern that despite this sentiment, is that providers should be paid less because they are saving so much time. It's the same argument that we have for telehealth. It's like copy and paste. We've said that literally all the legal and regulatory issues that we're now about to face in AI, we've already done this 15 years ago with telehealth. So it does give us a nice playbook to reference. But I agree with you, Zuhal. And there's still the cost of data centers and data scientists that have to create these programs and these platforms. So your costs are just different, not less than. So CTeL will continue to have these micro sessions throughout the course of the year. We will also finish up this roundtable conversation tomorrow, which will begin at 9 a.m. and go to 1 p.m. There will be 2 conversations tomorrow that we will focus on. One is the declaration of a public health emergency for the clinical workforce shortage. And then the second is enforcement actions and compliance considerations for the clinical workforce shortage and addressing the impact. So we look forward to that conversation tomorrow.